participated in several studies on this issue. Well, first, there is still the question whether we should perform carotid stenting at the acute phase when we face tandem occlusion. We still don't have prospective data to support emergent carotid stenting, but there is a accumulating body of evidence suggested from retrospective studies suggesting that emergent stenting leads to improved recanalization rates and eventually into improved clinical outcomes. And this is reflected in the clinical practice of today. So I think most operators would probably try to stent the carotid at the acute phase, unless there is a very large clinical infarct or there is a late presentation or there is high bleeding risk. So once we decide to do the stenting, the next question is what antiplatelet treatment to administer. And we have even less evidence to answer this question. So we ran some retrospective studies, which can basically be summarized very shortly. More intensive antiplatelet treatment at the acute phase is probably associated with improved carotid stent patency without an additional intracranial hemorrhagic transformation rate. But this is, of course, retrospective data with all the limitations that occurs. And we've done these analyses at a single center level, a multi-center level. We've looked into the ETIS registry, which is the National Registry for Thrombectomies in France. And there are other groups, and notably from Spain, that have done similar analysis. So the results and the signal seems to be consistent that intensive antiplatelet treatment seems to be safe and effective to preserve carotid stent patency.